Good afternoon, everyone. My name is Naomi Berkshine. I'm the Executive Director of Harm Reduction International, and I'm really pleased to welcome you here to the second webinar in our series, COVID-19 and Harm Reduction Program Implementation. Just going to pause for a second as I see we've still got a few attendees clicking in. I'm really delighted to be here today with colleagues from the World Health Organization, UNODC, Input, and MDM, who have led us in organising this series of webinars, with particular thanks to Sam Hodgetts and Suchitra Rajagopalan from Harm Reduction International, who are running things behind the scenes. Today we're going to be doing a deep dive, a bit of a focus on opiate substitution treatment and on overdose and withdrawal symptoms and how practitioners on the ground are managing them in the context of COVID. Obviously, COVID is having a devastating impact upon all our lives, and this is magnified in our community for people who use drugs and for people who come to receive harm reduction services. So I think it's more important than ever that we use these opportunities to come together virtually and exchange. On behalf of the team, I'm acutely aware today we have a video from Myanmar, but all of our speakers for this particular webinar are from the global north or from rich countries. And just to acknowledge that before we start, and to say every time we set out to do one of these things, we seek to get a diverse range of speakers. But on this particular occasion, this is the combination that we could come up with. But fortunately, you're going to be stuck with a great run of speakers today. Quickly, before I introduce you to our speakers, I wanted to note that what we're seeing in the context of COVID is a remarkable rise or triumph of pragmatism, which kind of defies all and anything we would have expected even just 4 months ago. We see this particularly in relation to opiate substitution therapy, which is like tensely and strictly controlled by drug policy under normal circumstances. We're accustomed around the world to quite a paternalistic, daily supervision style approach to opiate substitution treatment, and under COVID and the situation of lockdown, we've seen a huge relaxation of the restrictions placed upon practitioners prescribing, upon distribution of OST, upon induction and initiation practices, even in some countries. Harm Reduction International has been tracking some of these changes around the world. We think that there's examples from 30 countries at the moment of policy directives or guidelines or Ministry of Health instructions to change practice in the context of COVID. And so this is really exciting because it's something we've been advocating for years and have been unable to achieve until we see the shock of the pandemic upon society. So beyond the immediate imperative of obviously ensuring that people are safe and healthy, we're really excited to be speaking to you today about how we retain and hold on to those small progressive changes that we're seeing in the context of COVID. My colleague Monica Chapagia from UNODC has a few comments on this as well.
Okay,
there we go.
Now it's good. I know, I couldn't unmute. Thank you very much, Naomi. I'm Monica Chupaja. I'm the expert on drug use and HIV in the UNODC HIV program. So I'm really very happy to attend this webinar and to be here with you. As Naomi was saying, talking about opioid substitution therapy and overdose, it's very timely, and it's good to show the progress that was made. We are for 3 months already in this pandemic, and as the countries are trying to reopen, it seems like we need to learn to live with the virus and to adapt to what is needed in order to protect the society, to protect the most vulnerable people of the society, and also to be able to continue our lives. So I will show you a little presentation that I prepared for today. So from the early days of the pandemic, immediately when the lockdown started, UNODC made available a web page on COVID and HIV prevention, treatment and care and support for people who use drugs and people in prisons. And there you can find the latest information that is issued both by UNODC, but by other agencies as well, like WHO or UNAIDS, UNDP, and so on. We produce technical guidance that it's addressed both to the service providers and to the clients of the services. In this technical guidance, we strongly support the take-home opioid substitution therapy doses for people in stable condition. We also make a strong case for prevention and management of overdose during this time, and of course for providing both the service providers and outreach workers with means to protect themselves, like masks and gloves and protection equipment, and also reducing the overcrowd near the service, the HIV services, harm reduction services. So here you can see the one, the infographic for the service providers and the one for clients. They are translated in very many languages. They were all sent to our high priority countries, 24 high priority countries, and they were translated and made available in the local languages and also adapted when needed. The same, we issued guidance for people living and people working in prison. Apart from issuing the guidance, we moved to organize online trainings like the one we are having today. We also organize in collaboration with WHO and UNAIDS regional webinars for decision makers. One was already happening this week on Tuesday. It was attended by 101 participants from Southeast Asia and South Asia. And the major outcome of this webinar was that countries in that region were quick to implement take-home opioid substitution therapy in India, in Myanmar, in Nepal, in Bangladesh, in Indonesia, and also in Vietnam. And the reports that we received from the heads of these programs were that actually there were no problems so far. There were very few overdoses, only in few countries, and people are taking the medication responsibly. So I'm looking forward for the discussion today, and I hope that we will have the opportunity to talk more about the implication of on how to provide safely opioid substitution therapy during the COVID pandemic, and also how to maintain the results that we achieved so far. Thank you.
Thanks, Monica. So the first section of our webinar today is going to be focused on OST with speakers from WHO, Dr. Nicholas Luhmann, Dr. Till Kinkel, and then a video from colleagues in Myanmar. After that, we're going to go to the overdose and withdrawal section of the webinar, with Till and Nicholas chiming in with insights again. After that, I'll be handing over to Matt Southwell from UrinPud and Mauro Guarinieri from InPud, sorry, Matt's from UrinPud, to guide us through a question and answer session. Now, it's worth noting, if you do have a question, you need to type them in the questions line, not the chat line, in order for Matt and Mauro to be able to pick them up. And please note that this is being recorded so we can share it with people afterwards who aren't able to join at this time. Without further ado, I'm going to turn to Nicholas. Nicholas has been in the area of hepatitis C for more than 10 years and moved from MDM to the World Health Organization about a year ago now, I think. Please take it away.
Thanks, Naomi, and thanks, everyone. I guess you hear me? Yes. Can you hear me? Just to confirm, yes. Hello, everyone. Good afternoon, good morning, maybe people from the Americas joining as well. This is really a great initiative and has an amazing turnout, so that's great to see. So before Till will talk about more practice examples, just a short introduction from World Health Organization. First thing I wanted to highlight, actually the site from UNODC is really helpful, and those tools are really helpful. The second thing I wanted to say, I think it has been a little bit touched upon already, but these are really unprecedented times, and it's important to remind ourselves that people in general from key populations and people who use drugs in particularly difficult situation, maybe in some contexts to the lockdown. And there are reports of increased human rights violations, stigma and violence in this situation. So I think this webinar series really tries to facilitate some evidence-based and human response to this question. Another thing I wanted to highlight as a third point is maybe sometimes we get questions, and this might relate to some of the people who are listening in and the interests, how HIV, hepatitis, viral hepatitis and TB overlap with severe COVID disease. I think for HIV and viral hepatitis, there's no evidence so far for controlled HIV disease and viral hepatitis B or C if people have not very advanced disease, that it increases really the appearance of severe COVID disease. If HIV is uncontrolled and maybe people have very advanced liver disease, that might be different. In terms of TB as a pulmonary disease, especially when it's active, obviously we suspect that there's a strong overlap with severe COVID. Another thing before I talk more directly about OST is to say that we have heard as well a lot of reports about interruption of healthcare services in general. And I think it's important to say that for countries and member states, they will have to take some decisions about what are essential healthcare services, because it would be not fair to imagine that everything can be continued as before. So some of the really important questions, and that is not a question that's easy to answer, is what are essential healthcare services in this setting that absolutely have to be continued. And in the language and documents that have to be that have been developed by WHO, for example, we always stated that harm reduction and especially OST and needle and syringe exchange programs should be considered essential HIV, hepatitis prevention and treatment services as well from the drug dependency point of view, obviously. Just wanted to highlight that. And then in terms of OST, just some practice considerations, but Till will go more in detail to that. So one area is around take-home dose. I think just to say again, this is recommended by WHO. You can look it up in the key population guidelines that have been consolidated in 2016. There it is to refer it as recommended for stable patients. That can, people will discuss that maybe. So that is obviously a standing recommendation, and it should be definitely considered from our point of view for several patient groups in this extraordinary situation. And we heard from Monica some very good examples, and indeed it will be very important to hear how this continues and if it can be documented. Secondly, just to say there will be patient groups that still need a clinic, possibly certainly take-home dose is not a solution for all patients, and so clinic visits need to be partially reorganized according to the general recommendations that include physical distancing and all the other recommendations within that pandemic. In the moment, important to highlight that it's very important that peer and healthcare workers have adapted protection material if it's accessible. Another point that it's a smaller group of people, but we should not forget about, is people who need to isolate or quarantine because of COVID disease. So people use drugs that have to isolate for 15 days, or because they have been close contacts. So there, obviously, the continuation of prevention and OST services should be definitely organized. And as well, not to forget OST continuity in prisons. And then as a last remark, before I hand over again, is that obviously this webinar is about OST, and I believe as well this is an absolutely important, essential service which has high priority for community continuity. But I wanted to mention as well the NSP community-based needle and syringe programs, and because they are a very important way to continue to reach out to often the most vulnerable and to keep a form of link with them in this very, very difficult situation, for example, for people who may live in the street or so forth. So it's maybe not to be forgotten. We hear that maybe they're deprioritized more easily than OST services, but they constitute a very important service type as well. Thanks, that's it for the moment. I'll come in shortly after, a little bit later again. Thanks, Naomi.
Thanks, Nicholas. I'm pleased to introduce Dr. Till Kenkel next. I'm really happy to have Till with us today. Till has helped build the Kabul model program of OST with MDM. He's a medical advisor in the expansion of the OST program in Nepal, and has worked with MSF. Most recently, Till opened a comprehensive care clinic for people who use drugs in Berlin, including a diamorphine treatment floor. Please, Till, thanks.
Yeah, thank you very much, Naomi, for inviting me. Hello, everybody. Good morning, good afternoon, good evening, good night, all over the world. I'm a medical doctor in Berlin, which is obviously a high resource setting, I would say. Even so, I'd say we don't talk about tremendous resources needed to adopt to healthcare for people who use drugs in the times of COVID-19. When we look into the situation or the problem, I think a bit of an analysis of what is really the problem does good, and it might be different depending on the setting you live in. Of course, SARS-CoV-2 is affecting all of us, but let's distinguish between direct and indirect effects. The direct effects, which in the worst case scenario is the COVID-19 disease, versus the indirect effects. The effects on people who use drugs, the direct effects are not so overwhelmingly concentrated among people who use drugs, at least to my knowledge. I don't see outbreaks of COVID-19 among people who use opioids, people who inject opioids. And when it comes to the attributable risk of severe cases of COVID attributable to the risk factor of substance use disorder, probably nicotine use disorder or tobacco use disorder is the most important one, because that might really interact with the disease directly. So far, I don't see outbreaks among people who inject drugs, but rather in settings like old age homes or cruise liners or people who visit football stadiums, but not so much in our target group or in our among our patients. But the indirect effects are extreme, and here I want to distinguish between two aspects. There seems, in Berlin at least, there seems to be no problem on the supply side of drugs. I have talked with quite some people, among them as well dealers, who say, well, there is no problem with the supply side. The quality of drugs is maybe even going up a bit, but there is a problem on the demand side, let's say, because people don't have money anymore. People can't buy drugs in the street because shoplifting with closed shops is difficult. Sex work with closed brothels and prohibited street work is sex-based sex work is difficult. Begging when nobody is in the metro is not bringing any money, and selling newspapers to nobody does not work either. So what we see is that on the supply side there is no problem, but on the demand side, people cannot afford heroin anymore or cocaine anymore. So here we see now an increase in getting OST in Berlin, which is for free, which is in Germany covered by the health insurance usually. And so it's for many people who are not yet in OST an option to bridge a situation where they can't go on with using drugs. On the other hand, with all the recommendations from UNODC and WHO and the reactions of the government of Berlin and Germany, we see that a lot of barriers have really dramatically been decreased on a political level. So that, for instance, we have indeed now programs where people can get let's say a voucher for OST, even if they are not registered in Germany, even if they are not having an insurance, even if they are not having a name. It's possible to get anonymous substitution therapy. You just go to an office and you get a voucher with very little bureaucracy. It was a lot of bureaucracy before, but it's not anymore. And that is thanks to COVID. So the number of people and the demand for OST has increased quite a bit. And we see a lot of people coming in now in our offices on a very low threshold level. But of course, we have as well our traditional patients who come rather in the with the objective of life-changing therapy or something. Of course, in our office, we use the traditional methods of protection of patients and staffs from overcrowding, with face masks and with distancing. And thanks to the weather, people can as well wait outside in the yard so that we have no crowds of people inside our facility. And I think one very important change was that we have extended opening hours from 8 to 1:30 now, because when you care for people and there is an additional problem for the people, then you have to care more, then you have to care and work more and not less. So for us it is not a good way to say, well, let's just put them on take home and get rid of them so that they don't get infected or that they're not infecting each other in our office, because we have to take into consideration as well that people might need the services, right? And they might need the social contacts. That isolation and quarantine has tremendous impact on their mental health, and that not everybody is treated well with a 1 month take home, even though it's possible. We had extended our take home medication quite a bit already before COVID, because it's reasonable and it allows people to live a self-determined and free life. But for the ones who profit from coming to our office, we rather change our office than not allowing them to come anymore. And what we do quite a bit as well is bring home methadone or bring home OST, which is now as well allowed in Germany, not only for doctors and nurses, but also for trained lay workers. Now that has been changed just a couple of days ago, so that I can even ask my 22-year-old son, who is a student of physiotherapy, to bring home methadone to some of my patients, which helps a lot, especially when they have some signs of infection, or when they are older and have no signs of infection, but maybe a COPD or other risk factors like heavy smokers, obesity, and 70 years old. So I rather treat them as a bring home. We do vaccinations for influenza and pneumococcal disease a bit more than before. Actually, the severest case of a patient I have seen in the last months was a case of influenza A. I haven't seen any COVID case, but a severe influenza case. You know, with the take home, we are not so much worried that this ends up in the streets, because I pointed out in the beginning that the problem is on the demand side, that the people cannot afford heroin. It's not that we don't have heroin in the streets now. The opposite is true. So in this case, there is no real black market for methadone popping up now, or more than before. It's rather less, because people don't have money to buy methadone either, and so they rather come now to the offices, which is a chance as well to get in contact with them. But we are not now fueling a black market with increasing the take-home dosing. Of course, we give extended information, education, communication, and protective measures like face masks, and of course, you know, we try to be nice. That is very, very true. No, we just try to be nice people. And for instance, usually patients have to give a deposit just because they have some bills with contributions to the medication. And we have just said, you know, we are now not going to restaurants anymore. We are not going to cinemas anymore. We are not spending a lot of money we have spent before. So maybe now it's time to leave no one behind and spend this money in the deposits of our patients or in their needs. And you don't have to be a messiah to do something like that, just to be a bit human and lower the threshold for people who otherwise would suffer opioid withdrawal. Yeah, this is the way we try to cope with it in Berlin. I'm happy to answer some questions later. But for now, back to you, Naomi.
Thank you so much. I do want to sneak in a cheeky question, though, because we've had a great question from Ina in Georgia, and it flows on well from what you were just saying. She's asking about, in the case of stockouts, how are you managing switching between long-acting and short-acting opiate agonist therapy?
How do we switch between long-acting and short-acting opioids?
Yeah.
Well, usually patients nowadays, the new patients come to our office because they are on heroin and they can't afford it anymore. So we put them actually usually in the beginning on methadone, which is in most cases the first choice. Some patients get morphine, and well, you know, what I do usually, I give a patient a dose which seems sufficient, and then I give a bit of take home for the first night so that the patient can cope with the first night. And so then in our office, usually the patient is on the driver's seat, right? The patient tells us how much he needs and how much he wants, because most patients know that. Switching back to short acting is usually not so much our business, right? We are in substitution usually switching to long acting, and we don't have stockouts.
Thank you very much. I think Sam has got a video queued for us from Myanmar.
COVID-19 ရောဂါကိုကာကွယ်ရှော့ချရေးစီမံကိန်းအနေနဲ့လှုပ်ဆောင်နေတဲ့အကြောင်းအရာတွေကိုကျွန်တော်အကျဉ်းချုပ်ဖော်ပြပေးတော့မှာဖြစ်ပါတယ်ခင်ဗျာကျွန်တော်တို့မိုးကောင်းမတရုံဌာနမှာဆိုရင်စီးလာရောက်တောက်သုံးသူစုစုပေါင်း981ယောက်ရှိပါတယ်ခင်ဗျာစီးတိုက်ချိန်ဟာမနက်9:00 နာရီခွဲကနေ17:00 နာရီအထိဖြစ်ပါတယ်ယခုကာလဆိုရင် COVID-19 ရောဂါပြန့်ပွားမှုကိုကာကွယ်ထိန်းချုပ်နေတဲ့ကာလဖြစ်တာကြောင့်ကျန်းမာရေးနဲ့အားကစားဝန်ကြီးဌာနကုသရေးဦးစီးဌာနမှလမ်းညွှန်ထားသောမတရုံ maintenance therapy guideline နဲ့အညီ take home dose များထုတ်ပေးနေပါတယ်ခင်ဗျာကျွန်တော်တို့ဌာနမှာဆိုရင်လက်ရှိပါဆယ်ရနေတဲ့လူဦးရေစုစုပေါင်းဟာ960နဲ့တယောက်ရှိပြီးတော့တရက်ကိုလူဦးရေ80နဲ့100ကြားအဖွဲ့များခွဲပြီးပေးထားပါတယ်တခါပေးရင်လူတစ်ယောက်ကိုရခင်က6ရက်စာနောက်ပိုင်း10ရက်စာနဲ့ယခုနောက်ပိုင်း14ရက်စာအထိတိုးပြီးပေးထားပါတယ်ပါဆယ်မပေးခင်မှာမတတုံးဆီယာမကနေပြီးတော့လူနာကိုစေးနဲ့ပတ်သက်တဲ့အန်ဒီရတွေနဲ့စီကံချက်တွေကိုတည်တည်ချာချာရှင်းပြပါတယ်ပေးတဲ့အခါမှာလည်းလူတဦးချင်းစီကိုစီကံချက်စာရွက်တွေဝင်ငှပေးထားပါတယ်စီထုတ်ယူရမှာလည်းလက်ကိုစနစ်တကျဆေးပြီးမှတဦးချင်းစီတန်းစီမှထုတ်ယူရပါတယ်
မင်္ဂလာပါကျွန်တော်တို့ကျော်ရင်းပါခုလက်ရှိကမ္ဘာ့ဆောင်များအဖွဲ့မိုးကောင်းမှာ community worker mentor အနေနဲ့တာဝန်ထမ်းဆောင်နေပါတယ်
စစ်ထုတ်အပ်ဖြန့်ဝေခြင်းလုပ်ငန်းတွေမှာစေရနာဝန်ထမ်း PR တွေကိုစစ်ထုတ်အရက်ပြန်မိုးရေကွန်ဒုံးတွေကိုနှစ်ပတ်တစ်ကြိမ်လုံလောက်အောင်ဖြန့်ဝေထားပါတယ် PR တွေက local dealer တွေနဲ့ချိတ်ဆက်ပြီးစေတုံးဆွဲသူတွေစီစစ်ထုတ်အပ်တွေရောက်အောင်ဖြန့်ဝေပေးပါတယ်အချို့ကျေးရွာတွေမှာ PR ရဲ့အိမ်ခြေတင့်တော်တဲ့နေရာတစ်ခုမှာချိတ်ဆက်ပေးထားခြင်းစေတုံးဆွဲသူတွေတွားလေးရှိတဲ့နေရာမျိုးတွေမှာထားချိပေးထားခြင်းတွေကိုလည်းပြုလုပ်ထားပါတယ်သုံးဆွဲပြီးစေထုတ်အပ်ကိုစွန့်ပစ်နိုင်ရန်အတွက်တန်ဖိုးငွေတွေလည်းတပါရီထားချိပေးထားပါတယ်အဲ့ဒီတန်ဖိုးတွေကို PR တွေက2ရက်တစ်ကြိမ်တွားရောက်တင်စီပေးပါတယ်ကျေးရွာလိုက် PR တွေကိုသက်ဆိုင်ရာ community worker mentor တွေမှာနေ့စဉ်ဖုန်းနဲ့ဆက်သွယ်ပြီးသတင်းအချက်အလက်များစုံစမ်းမေးမြန်းခြင်းနဲ့တင့်တော်တဲ့လမ်းညွှန်မှုများပေးခြင်းတွေကိုလည်းပြုလုပ်ပါတယ်
။ဘာဆရာများအဖွဲ့မှာယခုလို COVID-19 ကာရောဂါကာလအတွင်းမူရစ်ဆေးသုံးစွဲသူများအားမူရစ်ဆေးလွန်ခြင်းမှာကာဝယ်ကုသနိုင်ရန်အတွက်မူရစ်ဆေးလွန်ခြင်းဖြစ်ရာတွင်ကုသနိုင်သည့်ဆေးနာလိုသုံးများကိုကမ္ဘာဆရာများအဖွဲ့တည်ရှိရာရုံးများဘဝတူပညာပေးအရောက်ချင်းစီတိုင်းနှင့်လူလူအခြေပြုလုပ်တာအရောက်ချင်းစီတိုင်းတွင်ပေးထားလျက်ရှိပါသည်ဘဝတူပညာပေးများမှာမူရစ်ဆေးလွန်ခြင်းဖြစ်ရာတွင်ကုသနိုင်သည့်ဆေးရရှိနိုင်သောသူများနှင့်၎င်းတို့၏လိပ်စာဖုန်းနံပါတ်များကိုမိမိတို့၏ဘဝတူမူရစ်ဆေးသုံးစွဲသူများထံသို့လည်းဝင်ငှထားလျက်ရှိပါသည်အကယ်၍မူရစ်ဆေးလွန်ခြင်းဖြစ်ခဲ့ပါကသက်ဆိုင်ရာအနည်းဆက်ဆုံးဘဝတူပညာပေးသို့မဟုတ်လူလူအခြေပြုလုပ်တာများမှာချက်ချင်းတွားရောက်ကူညီပေးနိုင်ရန်စီမံဆောင်ရွက်ထားလျက်ရှိပါတယ်ခင်ဗျာ
Thanks very much to MDM for arranging that video. On a related active note, Ernst Wiest, who is the brain behind this webinar series, has an intervention to make at this point as well.
Hi there, my name is Ernst from MDM. Not really sure I'm the brain behind everything, but I just wanted to give a very short proposition to all the attendants. So we've been hearing of a lot of contexts where medical doctors are now suddenly shifting to different ways of prescribing. As you just saw in the video, some of our colleagues in Myanmar, our doctors now, they had to shift because of new regulations. They had to shift 1,500 clients to take home dose within a week. So of course, this is something they're very happy with because they've been fighting for take-home dose for a very long time, but it is also quite challenging to do this also quickly. So I just wanted to propose, if there's any medical doctors, prescribers out there that are willing to participate in a mentorship program, I'm very happy to arrange that. So I'm having in mind that if you're a prescriber that is now facing rapid shifting context, new ways of prescribing, that we bring together small groups of prescribers that you can talk in between peers, and then we can bring in as well some more experienced prescribers to all learn mutually from each other. So if you're interested in this initiative, please use the email that is in the chat or as well in the invitation. Thank you.
Fantastic. Now we are running a little bit behind time, but Monica has a relevant point on stockouts as well, which I thought we should just cover off on. So Matt and Mara can take the questions after the overdose session.
Yes, I just wanted to say, I mean, what I want to say is actually more relevant for the government representatives, but it's also good for people to know. In the webinar, there is this organization called International Narcotic Control Board, and they are able to help in this situation to change the country that is providing methadone. For instance, they helped Moldova. Moldova was importing methadone from Italy, and when the roads were blocked and Italy stopped producing, they worked with the Moldovan government and found another supplier in Ukraine. They did the same in Kenya and in a couple of other situations. So if you are in countries that are about to experience stock out, you need to know that this opportunity exists. You can get in touch with me, and I can direct you to the focal point in INCB, who can start working with your government to find another source of supply.
Amazing, thank you so much. So now moving to perhaps a slightly shorter version of the withdrawal and overdose session. To you, Nicholas.
Yes, I'll be short, but I think if I understand correctly in the chat, the question that you picked up from the Georgian colleague related as well, or it was formulated around, is it better in those stockout situations to use methadone or buprenorphine? I think as a prescriber, Till may want to comment from that angle as well. And we have heard similar questions in the preparation of the webinar. So just wanted to say that buprenorphine is a recommended therapy for OST, whereas tramadol is not. So if you have buprenorphine, that would be definitely a preferable solution, and I think that's the case as well from user perspective. Tramadol has been used in stockouts as a last resort, but it doesn't have really the properties of providing adapted OST. So with regards to the second part, just very shortly on supply, demand and overdose, Till has started to talk about it. I just wanted to say in general, the Berlin situation reflects maybe many other situations, but there might be differences across countries. In general, I think such a dramatic global situation will in many countries be the basis for change in supply and demand. And generally, when you see that, there is a risk of overdose. And in this specific case, there might be as well a risk of involuntary withdrawal. So both are relevant. In terms of overdose, there are reports that has been clearly reported. It's hard to say if it's more than before. There is one aspect, maybe the main one, that relates to COVID that may increase, in addition to supply and demand, the overdose risk, that is social isolation, or that people use maybe more often alone than they did before. In general, here again, WHO has a clear recommendation since 2016 that relates to the use of naloxone by people that may witness overdose. So that's a standing recommendation again that is more relevant than ever, I would say, because it's as well a recommendation that is totally applicable in the current situation. If people and peers and people that can witness overdose have naloxone, that is definitely the best way to deal with overdose in general, but even more so now. A last thing is that there are questions around rescue breathing. So this is not an easy answer to give. There's no specific recommendation for WHO for rescue breathing in a life-threatening situation, including overdose in the COVID contexts. But the only thing I can say that it seems from a general point of view of proportionality in medical practice, that if the person that witnesses overdose and would do rescue breathing feels capable of doing it and not completely at self-risk because of risk factors for severe COVID, it would seem reasonable or more than reasonable to do that. That being said, it can be understood that some people are really afraid in the current situation to do that because they feel themselves very vulnerable. So you can't prescribe that for someone, but it seems to be a priority when you compare it to the risk to just potentially be exposed to SARS-CoV-2. So that were my comments for that session. Thanks.
Thank you, that's so helpful. Back to you, Till, for some clinical insights.
Yeah, thank you, Nicholas, for adding to my comment before to the colleague from Georgia. Maybe I haven't got the answer, the question well. Absolutely, I support that buprenorphine is a much better substitution if you run out of stocks from methadone than it is tramadol. Absolutely. I support as well your statement on overdose and involuntary withdrawal risks in whatever unstable situation. You know, the situation of a scene of people who inject illicit drugs is always vulnerable to instability. And however, how would we react on that? And we have, this is actually as well how the, on what this webinar is about, no? I think with bringing down the thresholds to enter proper OST, that is already a very important step to alleviate involuntary withdrawal and to reduce risk of involuntary overdose. And I think another point I would like to make is that even with giving take home, for us it's very important to stay in contact as well to prevent overdose or domestic violence or suicidal risks. So of course we distribute to some, or let's say many patients as well naloxone, but for us it is as well normal that our patients do have our mobile numbers, and especially when patients living together as couples or in small groups, or two people in assisted housing, let's say, they do use as well our telephone numbers to call for immediate help. Instead of calling an ambulance, they call us on how to cope with an overdose. That is a helpful tool as well as for what I have said, to decrease suicide risks, depression risks, but also as well overdose risks, and of course to enroll people into OST. But we haven't seen a lot of overdoses. We have seen a lot of involuntary withdrawals, which can be treated quickly with OST. But overdoses, I don't have the feeling that we have more overdoses. What we do see, and I mentioned that in the morning session already, is that a lot of people seem to overdose on alcohol currently, and we see a lot of people with relatively severe alcohol intoxications in the streets of Berlin. But that might be as well a result of the good weather, and before they have been in the houses and now they're on the streets. And maybe as well just a matter of boredom, which is as well relevant. Yeah, so far my comment to overdosing and withdrawal.
Thank you. That's probably a great place to turn to Mauro and Matt to take some questions. We had anticipated ending this webinar in about 30 minutes, so that gives us a good amount of time to have a discussion.
Yes, thank you, Naomi. Well, first of all, I would encourage people to use the question tab, not the chat, to write a question. Then we will ask people to ask the question. Just one thing that I wanted to say, that, you know, as a global community, people use drug. We've been really emphasizing the point that all this changes, that they don't have to stop after the crisis is over. So we've been trying to push for more like for more take home for people, for a lower threshold. So now we're having this, you know, a lot of countries implementing this because of the emergency, but we're also seeing that, you know, they work and they're not major crisis or diversion. So the point is really to encourage this to continue after the crisis. So
we have a couple of questions about this stock out issue, and I think maybe we can just maybe bring into this. Ina, do you want to maybe come and raise the question that you were raising before? If you could come, and then Dr. Sherzai from Afghanistan, maybe you could come on after that. They're both questions about stock out. Yeah. So, Ina.
Hello. Yeah, this is Ina from Moldova. I'm working with UNODC, and I actually have a question on behalf of the doctors, because I'm being called by the doctors from the community and from prisons. And in the situation that Monica has mentioned, we were basically facing the situation of stock out. Now it's kind of being solved, but yet the doctors are concerned what shall happen in the case we are in the situation of stock out, and which treatment shall be better applied. I think Nicholas has answered to that, so it's better buprenorphine and not tramadol treatment as short therapy. But the second concern the doctors are raising is how do we come out and switch back to methadone after these short medical interventions with buprenorphine. Do you have any advices on that?
I'm just going to suggest we take Dr. Sherzai from Afghanistan as well, and then answer both questions together. So, Dr. Sherzai, do you want to come and raise your concern about the challenges of getting methadone to Afghanistan, which Till knows very well as a problem?
Everybody, especially member in part. My name is Ahmed Javed Sherzai. I work at harm reduction assistance. Under my management in of Afghanistan, we have around 200 under EMT clients. But regularly the methadone from Italy. Right now, as you know, the 19 pandemic issue in Italy, how maybe face of and also in this situation. Because many border restriction regarding importation. Right now we have for 1 or 2 months, maybe we manage months, and after that we will maybe face with shortage of. My suggestion is that to go drug free our client, because my colleagues regarding we have methods in Afghanistan legal process. There is no we can find only we can bring Iran in but contact is with it to this for
Okay, so Doctor, thank you. Let's just take some advice on this key issue. So it seems that we have 2 different aspects of this issue. One is trying to avoid the problem in the first place, which is what Monica has highlighted in terms of the process that governments need to go through. And maybe Monica, you could just address that issue again, just to clarify for people. And then once we've maybe looked at the importation issue, then let's ask our doctors to give us some advice about the management of stockouts if they occur. So Monica, do you want to just maybe reaffirm to people what they need to do if they are facing a stockout?
well, it's better to do this before you are facing the stock out. You have to plan in advance. But the government agency who is in charge in the country who is producing or importing methadone or buprenorphine can contact INCB, International Narcotic Control Board, and they will help to find a different provider or to increase the capacity to produce in the country. So if you, and they already did this for a number of countries and it's working fairly fast.
Thank you, Monica. So that's really the key urgency, is get ahead of this when this is coming in, because if you are facing stockouts on the ground, they are pretty catastrophic. Till, I mean, I know you've actually been at the real hard end of this in Afghanistan when methadone ran out for the MDM program. Is there comments you want to make about what to do in those situations, particularly when buprenorphine isn't available?
Well, fortunately for me, I was not there when the stockout was taking place in Kabul. I have just left shortly before, but I know that this was a terrible time for the methadone program in Kabul when there was a stockout with methadone and people tried to use tramadol with, of course, non-satisfying results. Of course, you know, of course we have to adhere to laws and rules, right? But of course I know that from Iran there you could probably get methadone, and another option is to think about using opium, but I'm currently not aware of the legal situation of opium tincture. As far as I know, it was licensed even in Kabul, but I don't know if it's available or marketed. But of course, that could be as well an option. But I don't want to recommend here in this panel any illegal things. So please bear with me that I don't know the laws. That could be an option too.
Yeah, we know that Iran has had success of using opium tincture, my understanding, but it tends to be with lower dose users. And I think the big challenge for Afghanistan is that people tend to be on very high doses of methadone, which then makes it even more challenging when you're trying to switch onto short acting or lower dose opioids, which is the challenge.
Yeah.
Yeah.
But obviously there is no easy answer. No, if you have a stockout and you're on 200 milligrams of methadone, there is probably no way out than tapering significantly, right?
Yeah. So can we take this question from Aung C2? She's asking whether, under the current condition, we should stop enrolling people in methadone program or continue. I think it's an important question because, there may be some misunderstanding about it. Can you want to elaborate a little bit more? Can we unmute Aung?
Hello.
Please, Aung, go ahead.
Hello.
Hey, Aung, so
yes, go ahead. We can hear you.
Hello.
Yes. Go ahead.
Okay. No. After I listening all the presentation and the situation that I just would like to know about in the current COVID time.
Okay. So the question is
global stock supply are enough, or we should, stop enrolling people or, triage people compared to the past. And I'm sure that Till Nicholas might have something to say about that.
Well, I think Till said already that he is initiating new people. I heard that as well from India, I think. It relates to the other question. I think it's important how you manage that. with regards to what your procurement looks like. But I think if you have enough methadone or buprenorphine to prescribe for new patients, it is more than relevant. I think as supply and demand change, it is very relevant to think about newly initiating people, and it's as well an opportunity to bring people into OST if they like it. So I think the only that comes to my mind major criteria to consider is if you have actually possible stock problems. But maybe Till, you want to add something else?
Well, if you have no stock issues, I would definitely recommend to put as many people as possible in the current situation on OST, right? I think there is no question about it. If you have stock issues, then you go directly into an ethical dilemma. But it's you know, but if you have a food shortage, what is your reaction? Do you keep the stocks for the ones who have something to eat so that they have another 3 months to eat and let the others die? Or do you distribute it in a way that you try to get through as many people as long as possible? And so I could imagine that in such a situation, you do maybe a more rigorous assessment of who might do well with a taper or who might do well even with a detox episode, right? I mean, if there is not enough, maybe the second best or the third best is better than not providing anything. I would maybe as well strongly support harm reduction so that people might continue using the drug they come from in a safe way. But you know, this is difficult to sit in Berlin in a very comfortable chair and to think about the stockout situation in Kabul and to give an answer on that here. I think it should be individualized, the approach, but I would compare it with a food stockout or food shortage in a difficult setting, and then just to think about maybe tapering some, detoxing others, maintaining the third, or so individual. No?
So look, and I would want to emphasize that last point. Now, one of the challenges in Afghanistan is you've got very strong heroin on the ground because it's a producer country, so therefore people are on high doses of OST. The advantage is you've got very strong heroin on the ground. So actually, if you could sit there and talk to people, particularly maybe people who've been injectors in the past, to sit down and talk to them about smoking heroin as an alternative, getting people to think about practically, if I am going to face a stock out, how am I going to manage this? What are the self-management strategies that as a drug user I can take? So rather than just being helpless and expecting someone else to be prescribing to you and it to be about somebody else being in control, also looking at what control you can take as a drug user and empowering drug users to be aware of their ability to self-control if they can afford the drugs. And that becomes the challenge that we're seeing right now, which is many people are struggling at the bottom end of the market to afford to be able to buy the drugs. And that's why I think we need to make sure that OST is as accessible as possible at this moment in time. Should we invite Derek McParland in to come and talk to us about this challenge of people moving from one drug to another?
Hello?
Ron?
Yes, go.
Hello, yes. So I work in Northern Ireland, and a part of the problem, we see an awful lot of opioid users with secondary drug use with particular benzos and pregabalin, and we're seeing an awful lot of black market, like flualprazolam and stuff like that, been disguised as normal benzodiazepines. So I'd just like to get people's opinions on how it's affecting, across the world and what effect the lockdown has, considering we know, especially in Northern Ireland, that we get an awful lot of our black market medication is over the internet from the likes of China and stuff like that. So just like to know what way it's gonna, you feel it's gonna affect users at present.
Okay, so this is the big fear about people transitioning from one drug to the other, and also people maybe falling onto the black market, onto the dark web, particularly to source drugs. Anybody got any particular comments on that one? drug mixing?
Well, I personally, I'm struggling a lot with people who use pregabalin, which is in Berlin quite common, especially amongst people with a Russian background, and which is, from my point of view, a tremendously dangerous and silly drug. I would never recommend that. But I know that in an acute withdrawal, when you can't find heroin or methadone, it might help alleviate withdrawal for some people in the acute phase. But it is causing quite disgusting withdrawals once you have taken it for a long time in many patients, not in all, but in many. And I do not recommend using pregabalin as long as you can avoid using it. There might be the exception for people who are living with an anxiety disorder or neuropathic pain, but as a treatment of opioid use disorder, I personally have strong objections against.
Yeah, the other drug we see a lot of switching between at the moment is spice, this synthetic cannabinoids, and which are mixed up with a whole degree of different things. We definitely see a lot of street drug users who talk about switching backwards and forwards on days when they can't afford heroin, they end up taking spice. Our concern is that while it does seem to cover people in terms of withdrawals or their discomfort, I worry that they're dropping their tolerance on these off days and that might then increase their rates of overdose. So I think particularly as we see this population at the bottom end of the drugs market with the least economic power, that group I think we really need to watch out potentially the switching both with benzodiazepines and also with alcohol and also with spice. I think those are the things we might well see. Okay, so we also go, Mara, you go.
Yeah, no, there is a question from Maria Mijovic, mentioning a specific situation in Montenegro where apparently it's not an option to admit new people on OST. I think it'd be interesting to know more about this specific situation.
Can you hear me?
Yes, very well.
Okay. Hey to all from Montenegro, from Podgorica. I'm Maria from NGO Juventus. We are working for a long period of time with different groups at risk. So the thing is now in Montenegro, there is no option for admitting new people to OST. We have only methadone and buprenorphine. We are also, because of ban on leaving the city of residence in our country, we have a bit of change in supply. Also, as many of you told before, there's a change in demand, so people are not able to get money to get the drugs. So we have a lot of people that are using alcohol with pills because they want to prevent withdrawal, you know, and we are trying to do, I mean, everything that's in our power, because we're providing harm reduction services within our organization and haven't stopped doing that during this crisis. But we are not we don't have naloxone to give to our clients because it's not permitted by our law. So just public hospitals have naloxone, and basically that's the thing that's now happening in Montenegro. So we have limited amount of people who can be included in methadone therapy. That is 50 people per city. So Montenegro is not a big country. We have around 700,000 people, but 50 person per city is very low. For buprenorphine, we don't have the limitation, but in a pandemic situation that we're in now, we have the answer from OST sites that new persons are not admitting at this point. Hopefully that will change as some bans from are, how should I say, lower, yeah, and we're hoping that will change. But so far in this month and a half, that's that has been the case. Thank you.
Because you have a problem importing methadone and keep the stocks?
No, we don't have a stock out on methadone. We had a problem when we started doing buprenorphine that was out of stock for a while, but that was a short period of time. And since it's on a government, not on CSOs to supply people with methadone and buprenorphine, we don't have an issue with stock. That's just some regulation that's not very good, you can imagine. So that's the law now. Hopefully it will change.
Maybe just to say something that comes to my mind listening to you to tell to others is that somehow the initiation of new clients, it's almost the indication has changed a little bit. You know, in your long-term methadone program, you have eligibility criteria and so forth, but parts of the patient who want to now be initiating OST with methadone or buprenorphine might be having supply issues and be in acute involuntary withdrawal. So I think that might be part of the discussion and advocacy to say why people should be actually induced and initiated, because this might be a much higher number of people who face that problem that might be actually not life-threatening in part.
Can I ask you, in Montenegro, do you have issues with heroin supply now, or is it as well an issue of people don't have the money anymore to afford heroin?
Well, as far as I know, which we get our data in direct contact with our clients within drop-in center and outreach, we don't have a problem with supplying heroin as much as the prices went up, because the base that the heroin is mixed with, it's more expensive. The prices went up. And as far as we know, now we don't have any issues with supply. But if the situation continues like that, I assume like in very short period of time that will be the issue too. As well, regarding demand, people don't have money to buy heroin or cocaine that are using regularly, so they are mixing alcohol with the pills. Basically, they can find in their houses with their relatives, or basically any pills they don't choose. So that's a big issue, I think.
Yeah, and the idea which Niklas mentioned as well, that the indication is now in many patients rather bridging instead of really MMT, let's say, or let's at least start it as a concept of bridging, or maybe even opioid-assisted detox at least, right? So that people don't have to go into cold withdrawal, but that you ask in the hospitals, if there is no option to include somebody in MMT, maybe there is an option to do an opioid-assisted detoxification within 2 weeks. I mean, I'm not in favor of this therapy, but better than nothing, maybe. When it comes to alcohol, I have patients too who sometimes drink alcohol, and then from the OST doctors, they don't get their dose of methadone because they have alcohol, and then they go stepwise into methadone withdrawal, and then they drink against the methadone withdrawal, and that is a vicious circle then in the end, that they don't get methadone anymore, and they drink and drink and drink and drink. And that is actually a classical moment where you need actually a harm reductionist and a doctor who just break this circle and try to get opioids back into the person, right?
Yeah. Do we have time for another question?
I'm not sure we do it. I just wanted to let you people know that I just posted into the chat a resource that was developed by Dr. Adam Winstock in the UK, which is we've been using as an advocacy tool that really helps doctors think how they can get people onto opiate substitution prescription without doing urine testing or saliva testing, given the potential risks of COVID-19. And I think it's really important to emphasise that testing just tells you that someone used opiates 2 days ago. It doesn't necessarily tell you about dependency or tolerance or dosing. So we are always using our clinical judgment to decide, a range of clinical judgments are made to decide whether to take someone onto OST and what dose to give them. Urine testing is optimal, but it's not essential. And I think we should be using our clinical judgment and not using that as a barrier. I think the other thing we want to highlight is that while buprenorphine is being used where both options exist, methadone and buprenorphine is often pushed as the frontline option because it's lower risk for the doctor. However, for many of the more chaotic drug users, it's too high a threshold to jump into. If they're on the streets, switching to buprenorphine can be quite challenging when you've got to go into active withdrawals before you start on buprenorphine. So I think if we're really trying to engage those most marginalised drug users, we need to have a range of options, and we're probably going to need to come back round several times to engage them. Anybody else want to add anything else? Do we want to do another question? I think we're pretty close to the end of the session. Shall we pass back to Naomi to wrap up? So just say thank you all very much for your contributions. We will be doing another webinar in this series, which is going to be looking at non-injecting drug use and stimulant use and COVID-19. We were going to have a bit in this webinar, but we've decided to expand the topic to a third webinar, so we'll come back to you about that shortly. But let me pass over to Naomi, and thank you for a great discussion.
Amazing, thanks Matt, thanks Mauro. On a similar note, if you have a contribution, you want to be a speaker to this webinar series, please don't hesitate to reach out to this team of people. There's an email address where you can reach Sam and Ernst on the invitation. Just to echo what Matt said, our hearts and our thanks and our solidarity to all those service providers out there that are providing critical services right now, but also to the leaders of the community of people who use drugs who have really leapt into action in an absolutely incredible manner. And Matt, your translation into 20 languages over the past 3-4 weeks is incredible. In particular, I think of that. And when we look beyond the immediate and urgent need to look after people, to care for people, as Till spoke about, we really need to think to the next step, which is about preserving the progressive changes that we see happening, in the pragmatic conditions and the pressure of the pandemic. We do have quite exceptional circumstances. I note when we look at the different changes around the world at Harm Reduction International, we note that a lot of the regulations, a lot of the directives, a lot of the Ministry of Health guidelines are very specific to the COVID pandemic. So the flexibilities for OST prescription are provided just for the period of the COVID lockdown. And it's going to be so important that, we have the evidence to show the sky has not fallen in under these flexibilities. As Till said, there's very little anecdotal evidence right now of any diversion, which is an issue that most opposition kind of rises around in my experience. I think it's also really important to go back to decision makers and governments in our country, remind them that most countries have in place limitations and restrictions on prescribing around controlled medicines that are above and beyond what the international drug control conventions require. There is more flexibility in there than most countries are taking advantage of when you think about prescribing and delivering and storing of controlled medicines. I was really happy to hear Nicholas emphasize and Monica through the UNODC guidance that our harm reduction workers are essential service providers in these times, and to get this vital information about stockouts. Stockouts are a huge difficulty we're going to be facing in the coming months, but please take direct action. Way back in March, the International Narcotics Control Board issued a press release which emphasized the importance of, extraordinary conditions requiring an extraordinary response. So please reach out to Monica or your UNODC focal point to make sure you're accessing the right people to talk about stockouts if they're an impending issue. Broadly, I love to hear from Till and Nicholas about the patient-centered approach, treating people as people, considering them as a whole, and I think that our OST prescribing needs to continue along those lines going forward as well. I think just in final points, huge thanks again to Ernst Weiss at MDM for leading us in this webinar series. I really hope to see, you know, our community continue to survive through these challenging periods. I think if there's any community that's set up for it, it's ours. The basic principles of believing in inherent human dignity, in following leadership from the community of people who use drugs, and thinking about the whole person. What I do want to leave you with is the thought that going forward, harm reduction is going to have to be more all-encompassing and more inclusive than ever. You know, in the post-COVID era, forgive the platitudes, we are going to be looking at extremely resource-constrained environments. People will have lost their jobs. They may be more in need of shelter than ever before. So harm reduction needs to mean food, needs to encompass shelter, it needs to consider mental health, needs to consider gender and domestic violence, which is mentioned as well. So please continue to advocate for harm reduction in its most wholesome and most all-encompassing manner.
Okay, so shall we, maybe if we could start, well, thank you very much for the really interesting range of speakers, really informative and really great to hear about really compassionate care for people who use drugs. I think many of us are involved in trying to advocate for enhanced services for people who use drugs, and in many ways this virus has got us some of the gains we've been fighting for around take-home doses, around rapid responses to treatment, around accessible harm reduction that we've been fighting for decades. So I think there's a real opportunity now that we start to ask the question, why should this not continue on the other side? So let's open up the questions. We have a first question. Elizabeth, would you like to maybe ask, you had two questions to our two doctors really about, one about patient involvement and also about quick policies of getting people quickly onto OST. I don't know how we bring Elizabeth on. How do we do that?
Hello, everybody. I'm Elizabeth from Paris, and I wanted to know if we try something in Paris in our DCR to register people from directly in the DCR from for OST. And also because we had very quickly we tried to find hotel for people, for the most vulnerable people. So we have more than 150 people put in a hotel alone. And as you said, loneliness is very difficult. So we have a team going every day to the hotel and to check. And twice a week we have a psychiatrist going in the hotel also, because we have many problems because people are isolated and they have no place to go and to talk. And I wanted to know if in Berlin, in the DCR in Berlin, you had this same politic and you know, reaching people, new people. And we have also peer educator, and they come with people who would like to have OST quickly. And this registration is more or less like we call in France dépannage. They are not, they don't have to come every day to take their OST. It's only if they are running out of drugs and out of morphine, they can come and have substitution therapy. That's my first question. If you have sort of a very, very low threshold program.
Yeah, probably this is directed to me, this question, right, to Berlin. Yes, we do have this very, very low threshold, as you put it now. I mean, usually, I mean, the classical OST would be a person who is, so to speak, in the contemplation phase of behavior change, wants to get over it and so on, comes to your office and discusses with the doctor in hours and days of talking about new goals in their lives and how to manage and how to achieve this and that. And so this is very often the entrance point for classical patients who want to really change somehow their way of life in one or the other way. Now we see quite a lot of people who have much smaller goals, right? They want to survive the day without withdrawal. And yes, we do have, but this is not in our office particularly, this is from our city of Berlin. We do have an office where even people who are not registered in Germany, people who have no insurance, and even people who have no name can go and can get a paper saying the doctor who is doing substitution therapy for this person is paid by the government of Berlin. So that is what I call very low threshold. And I have, last week I had 5 patients, I actually don't even know their real name, who come just for a certain time to get stabilized in this setting. So we have problems because otherwise we wouldn't have these patients coming in, but we have these very, very low threshold programs in Berlin. And of course, I don't ask a patient to, I don't come up with obligation to come every day, right? I mean, the patient comes when he needs me and I'm here, right? And that's it. And that might be different for somebody who wants to change his or her life than to somebody who wants to survive the day. Right,
right. Thanks,
Okay.
Till. Yep. Nara?
Sorry. We have also another, we have a couple of questions from Richard Francis. One is about gaps in access to OST, which is, of course, a good point. And another question for Till about the increased risk for COVID for people who smoke marijuana. So if we can unmute them. Francis?
Hi, I'm Richard. Good morning, good afternoon from India. I have 2 questions. First, thank you for this webinar. I missed the earlier one. I was down with fever, but I'm better now, thank you. The first one I had addressed to Matt. Matt, I heard a lot about you and your work in Afghanistan especially, so I'm hoping to probe your mind a little bit. I think we're doing some good work in terms of access to OST, OAT, despite this epidemic, but yet I have come across quite a few cases where I see serious gaps. And it's an open question perhaps for the next pandemic. Hopefully we do not get into one. It is, I think, universal access is required. I'll tell you why. We have centers, we have OST centers, but still sometimes, as in India, you need to go from state to state, and sometimes the state borders are closed. So what happens is that friends, colleagues call up each other. Hey, can you lend me a few milligrams? Can you, it's a give and take. Of course, you share when you can, but I can't give away my dose. I'm an OST, I don't want to go into withdrawal. So in that case, where do you go? All right, there's a black market. But in this lockdown, the black market is difficult to access. The easiest way to access OST would be to the chemist. I still don't understand, and perhaps I'm asking your advice. How do we advocate for a government nod to an OST center? Sure, we open.
So Francis,
that question is posed to Matt from experience.
Okay, thank you, Richard. Sorry, you're slightly cutting out at the end, but I think we got your main question, which is about the limitations of OST treatment and how we can try to scale up access and have more universal access. I think it's one of my big bugbears is the fact that we make OST very, very expensive because we don't trust people who use drugs and we don't make them partners in treatment. So we design OST treatment on the basis of the sort of 5% of people who have very, very severe substance use disorder with multiple complicating mental health, homeless, social factors, criminality, a whole array of problems, and we design the system for that group, and then everybody else has to work to the same levels of restriction. And I think we need to come up with a much more sophisticated model that is able to cope with the most complex and offer them a rigorous, comprehensive service led by psychiatrists, led by people with the multiple skills able to support that highly complex population, but then recognise the vast majority of people can be active partners in treatment and can be engaged with, have huge knowledge of their own OST treatment and can manage perfectly successfully. And I think we'll see as we come through this period a large number of people doing very, very well with weekly take-home doses, probably cutting their use down, managing, having positive outcomes, and then there'll be a small group that manage. And I think I'm already seeing the treatment system doing really badly once again in the UK with that group who really struggle. If they were given scripts early on, then they lost their prescriptions, then they didn't make it onto buprenorphine, and the system is very poor and almost resentful at trying to respond a second time to the complex clients. And when I hear the sort of complexity of response in Germany, I'm very envious. Tils or Nicholas, do you want to add, or anybody else?
Well, this is a great point, Matt. Thanks. Maybe to add that beyond the structure of the services, I think in many countries, including in Asia, the price of methadone literally is as well, and buprenorphine as a procured drug remains still sometimes far too high, and that drives as well the prices up. I don't think price is the only limitation today in scale up of OST, but it comes out as really one core limitation for low and middle income countries, for example.
Okay, so shall we bring Austin Smith in to ask a question about diamorphine and the role of diamorphine at this time?
Austin Smith, I'm from the Scottish Drugs Forum in the UK. My question was in Glasgow, where we have a very small heroin-assisted, diamorphine-assisted treatment system. My question is are we missing an opportunity here to expand the provision of diamorphine, which would keep some people in treatment after things change and the supply improves and people can get out and about and buy drugs? We can keep people in treatment by doing that initial offer of diamorphine, surely.
Till, do you want to go with that one first as a diamorphine prescriber?
Well, for diamorphine in Germany, it doesn't look like they bring down the barriers to access diamorphine currently. We are in the lucky position that we have just opened a new clinic, so we still have enough, let's say, diamorphine for everyone who wants to get it, right, and who is treated well with it. But of course, this situation will change as soon as we have, let's say, 100 to 150 patients. And then again, there will be restrictions. So currently, I don't see that the German government is making things easier here. In Switzerland, where we have oral diamorphine, that would help a lot, but I don't see that we get that just because of this little virus in the rest of the world rapidly rolled out. However, it would be, of course, as always, it would be nice to have more options to treat patients properly, right? All these restrictions we have, or many of these restrictions we have, are not based on medical or human reasoning, right? I mean, I would like to have as well sometimes, let's say, hydromorphone maybe for substitution, or and of course I would like to have diamorphine as well, because that would help a lot. But yes, the barriers are here not to be lifted just because of Corona in Germany.
Right. Okay, Mauro, do you want to?
Yeah, no, just looking at the question, I found this interesting from Ramin asking about alcohol harm reduction, and Gil mentioned this as a risk, especially in this and during COVID. And maybe we can unmute Ramin Ratfar.
Hi, hello everybody. Thank you for this fruitful webinar. Actually, in Iran, you know that ethanol is banned by the government and the religious, but it doesn't mean that the people don't drink alcoholic beverage. Usually, the alcoholic beverage that are available in black markets are handmade and prepared from the ethanol plus lots of the other color or essence or something like that. During the COVID-19, when the ethanol price of the ethanol increased and access to the ethanol decreased for those black markets, they started to adding the isopropyl alcohol and also methanol to the alcoholic beverage. Just in less than 1 month, we have about 1 month, we have 700 deaths related to alcohol. Is there any option that we can circulate among the, except of the information, education, and communication strategies? Is there any option that can be circulate among the peoples to detect methanol impurity in the alcoholic beverage or not, or any other harm reduction strategies?
Nicholas, do we want to try and grab you one last comment from you, and do you want to maybe make a comment on this around strategies for alcohol dependency? Is that, or is that one someone else wants to pick up?
I don't have a major comment or contribution to that. Can you reformulate the question? I wasn't sure.
Yeah, it was more about, I think my understanding was it was about asking for advice around strategies for managing alcohol dependency. Was that correct? Have I got the question right?
Okay. Yeah, well, what I have heard was the question. I have heard the question if there is any means to easily detect methanol in alcoholic beverages as a matter of harm reduction, so to speak, at drug checking for alcoholic beverages. And I'm not aware of that, but maybe one of you is more knowledgeable on that. Is it easy to detect methanol in homemade alcoholic beverages? I don't know. Anyone else knows that?
So what we'll do is if anybody else knows anything about this, please send your answers on a postcard to us, and we will share it back out with our responses of this process. So I want to go to Myanmar and ask Ong Mo Thet to just, he has an interesting example of an overdose that took place in Myanmar around someone sharing their methadone. Ong Mo Thet, do you want to come and share that?
Oh, she might have left. Yeah,
okay, so let's raise that question then, because I think one of the concerns we have is, of course, from a drug user point of view, being given weekly take-home is a huge opportunity. It gives us much greater flexibility, takes us away from this paternalistic form of treatment. And among my peers right now, I was out seeing 2 drug dealers in heavy withdrawals last week because nobody would sell them their methadone. So what I see at the moment is a real lack of diversion going on. Clearly, I think people are worried about diversion. I don't know if other people have got lessons or issues that they want to raise around how we can support people who use drugs as we give people more flexibility.
Yeah, I would definitely support you in that, Matt, because, you know, when I hear that people are now slipping into withdrawal because they can't buy methadone anymore on the black market, that is really horrible, because why do they buy it in the black market? And that is because the barriers to the normal treatment are just too high, and that is very often the barrier of being treated like a little child or being treated in a disrespectful or stigmatizing way, what a lot of people do not want and then prefer buying methadone. The same methadone they could get for free in an office of a doctor, they better or they prefer to buy in the streets without being treated in a humiliating way by a doctor or somebody who knows better. And I think there we have to work, because it's really disgusting to hear that somebody slips into withdrawal because he can't find methadone on the black market. That is a sad story. But we have that, of course, in Berlin too.
Yeah. Yeah. And I think one of the things that I would also highlight to you is that we have a video series that, in fact, we shot the first video for yesterday, and we're just in the editing stage, which is a Euro-input series called OST in a Time of COVID-19. And we're going, and myself and Christos Anastasiou from the Greek drug user group PENUPS, we're going to be co-hosting a series of video discussions between experts on OST, both peers and professionals, to talk about the opportunities that we now have with this relaxed treatment environment, and to see how, as advocates, we can maintain these changes on the other side. And part of that is actually making sure that we have the best outcomes that we can by offering self-support in this time. So please watch out for this video, which will be, or this video series will be coming soon. Until will definitely be on our list of people to come and have a chat to. Okay, so we also had Dr. Amjad Chowdhury. You were raising an interesting issue around the wider issues of the lives of people who use drugs: employment, homelessness, depression, economic challenges. Do you want to come along and set that question to us? I think you're on, Dr. Amjad. Dr. Amjad, can you hear us? We can hear your bird very loudly.
Yes.
Please ask your question.
I'm just talking about we are talking a lot about the clients, patients who are suffering from the COVID and everything. We are very seldom talking about the professionals who are suffering from jobless, as well as they are unable to deal with the client. They are living at home and they are difficult to doing the professional practice, and they become depressed, they become irritable, there are mood swings as well. So there must be something we have to talk about them as well. So we have to keep their health okay, because they are important people, they are important stakeholders in the opioid use treatment. Thank you very much.
Thank you, Dr. Amjad. I actually misunderstood your question in the writing, and it's actually a very interesting question about the welfare of people working in the system. I mean, I think many of us were already concerned, particularly about workers dealing with the huge impact of the opiate overdose epidemic around the world. And we've been losing friends and peers at a horrendous rate. And I think the impact on peer workers and professional workers around the world shouldn't be underestimated. And now we have COVID-19 on top of that. Any comments from other people about strategies for resolving this, or comments around this topic?
Matt, if I may, I think essential is, first of all, to provide outreach workers and workers in the methadone clinics with protection equipment at the adequate standards, so people are not, first of all, feeling exposed, and also, put in danger. Also, I think we heard about working hours, and that's another issue, making shifts and making sure that people are safe, both with regards to the virus, but also preventing the burnout, because these are exceptional times, and these are times when people who are providing services are also in need for support. And then all the measures put in place to reduce overcrowding. And for outreach workers, it's important also to have, because restrictions in countries varies from country to country. So restriction of movement is an important issue for outreach workers. They need adequate permits, so they won't come at risk of being arrested because they are on the street and they cannot justify their presence on the street. So I think these are all issues that have to be taken into consideration very seriously, and make sure that they are in place.
Yeah, I think that's very important. My background as a Greek counsellor from the early HIV days, I also think we need to just look at the consequences of managing a very high death rate among our client groups. I think we're seeing death rates that are well exceeding the early HIV days in North America right now with opiate overdose, and I just think we need to look at that emerging and create a time where we can talk about that.
Yeah, it's not a case that we see a lot of people that come from the early days of the AIDS epidemic being also managing this situation, because it's very similar in terms of impact on the community, in the way it just changes social relationship, but also on the impact on doctors. I remember, a lot of people being really, frustrated for not being able to offer much, which is the situation right now, because it's more like, putting people on respirators. It reminds me a lot about, the AIDS epidemic. So yeah, I think that's a good point. There is another question.
Let's go.
Can I add just something, because when Matt didn't get the question at the beginning, I think that's also a very important point to raise, is the well-being of people, because maybe in some countries accessing methadone can be addressed, but there is the hunger and the poverty that is affecting the communities. I mean, in the webinar that we had from with representatives from Southeast Asia, we heard about situations when people don't have access to food, they don't have the right documents to access the food programs where they exist in their countries. The restrictions of movement create also a lot of burden on their income and on their capacity to produce income during this time. So access to services is, of course, very important, and it has to be maintained and sustained. But also in many countries, we have to think about surviving from one day to another with regards to getting access to food and providing food and water for their families. And that's another issue that probably we need to discuss.
Yeah. Any other comment? If there no other comment on this topic, I would like to ask Roshan. It was a very interesting question about low threshold enrollment in OST program during the lockdown. Roshan, would you like to?
Yes.
Question?
Yes. Yeah. Yeah, I'm from India, and if you look at India, a lot of advisories has been issued by our National Health Control Program on induction of new OST or take-home dosing. But one thing that we have been witnessing is that besides all these advisories, there has been lack in induction of new cases into the OST program, because due to the lockdown, many people are not able to reach the OST center, and also many of the clinical medical officers that are engaged in our OST clinics has been engaged in the COVID-19 response, and there is lack of medical officers at our OST centers as well. So we are also thinking about setting up mobile-based induction for OST program. So is there any experience all across the world where there has been a mobile induction, or what are the things to be considered while setting up a mobile-based OST induction?
Yeah, that's a great point. Well, there's also like the flip side of what Matt was mentioning before, that all this program are really designed to make things difficult, and they're very infantilizing. Now we see that there is an attempt to simplify things, but maybe we have some example from the other panelists that.
Well, yeah, I'm aware of the really great mobile system in Berlin, which is run by Fixpunkt.
Yeah, exactly.
That, Till, or, I mean, I visited it, and it's a very impressive system, but I'm sure you have more direct experience.
Well, I agree, and it sounds a bit like Berlin is a paradise for people who use drugs, which is not. But yes, we have mobile methadone clinics and run by Fixpunkt, as you mentioned. We had them before COVID, and I'm not aware of them scaling them up now. I know that what came up now was a very low threshold initiative on a hotspot where they actually have just employed one doctor, but you need these human resources, of course. When I hear that all the medical doctors are now in the treatment centers for COVID and not in the treatment centers for people who use drugs anymore, it's sad. But we have just employed a medical doctor who was actually sitting on the hotspot, and the treatment was basically €100 for the doctor, €100 for the pharmacy, and then you take care of the patient for 1 month. And it was that easy, right? More or less in a tent. I mean, it was in the end of a fixed building, but the structure was really, it is possible. And of course, we would like to have it perfect, but this famous sentence, the perfect is the enemy of the good, is true here as well, right? I mean, we talk about saving lives and alleviating suffering, severe suffering, and so let's do it. Let's keep it easy. And we have these mobile clinics. It works fine, right? But it's not Berlin only, right? I think we have that in Myanmar too, no?
Right. Look, I think we've shown with the dispensing of morphine in African villages where nurses go out on bicycles and give medicine to people in rural areas, that we can be highly flexible with controlled drugs. The challenge is when we see drug users as the enemy, as people who are trying to deviate and manipulate the system, then we get into this battle. What I found is when I was running a very low threshold drug service that was specialized in working with people who were in that most challenging, chaotic group, was that you just had to be very persistent and very responsive. You had to recognize and not get frustrated with people, or at least manage your frustration that people kept failing and blowing up your plans. But people could then find their way in if you open this very low threshold, gentle entry into the system, and people then went on to make incredible changes with their lives. But if we don't get that low threshold entry right, we undermine the whole range of services that we provide to the most complex people. And what we end up doing is filtering out the most complex and leaving them outside the system when they're most in need. Just to let you know, I did share a resource from Adam Winstock, which is a resource about how to bring people onto treatment without doing urine testing, because I think one of the concerns is drug testing in the current COVID restrictions. I'm also going to send you the peer-to-peer naloxone resource from EuroMPUD, which is another key opportunity to recognise that peer-to-peer naloxone keeps on working under these conditions because peer networks carry on working. So let's enable drug users to keep the system going. We'll also be producing some resources, we hope, on secondary NSP, which is another way of keeping the harm reduction system going through drug users' work. I think we're now coming to the end of our time. So let me pass back to Naomi to just wrap up and bring this work to a conclusion. So thank you all very much for your contribution, for a fascinating discussion.
Amazing. Thank you so much, Matt. Really appreciate that. I think just to that last point as well, I hear anecdotally that NASCOP in Kenya is working with civil society on a standard operating procedures manual for their first mobile methadone distribution vehicle. And we know in South Africa, they've got a new guideline published, which is not so much about a mobile methadone van, but about multidisciplinary outreach teams going out to sites to support people to access the medicines they need and anything from withdrawal to OST. So in wrap up, incredible conversation. Beyond the immediate imperative of ensuring that people are safe and healthy throughout the COVID period, we know that we as a sector really desperately need to preserve the progressive changes that we're seeing, particularly around OST. There are many directives and regulations we're seeing around the world that are quite explicit that the exceptions, the additional flexibilities are provided only for this period, and that's not good enough. You know, we will have evidence from this period to demonstrate these changes are suitable and fit for purpose for all scenarios, not just a COVID pandemic. I think we also need to remember that most countries around the world go above and beyond what is required by the International Drug Control Conventions. There's much more flexibility permitted in national law for prescribing, for distribution, for storage of controlled medicines than what many countries are taking advantage of. To summarize some of the key points and some of the key takeaways, I really was very grateful for Till, Monica, and Nicholas emphasizing that harm reduction service providers and the peers involved in that are essential service providers. To have that recognized by you and ODC, and more recently by the Special Rapporteur on the Right to Health, is really powerful, and we should be using that. It's really important that we now have available to us a range of options to treat patients properly, to paraphrase, with the medicines that suit them, and we should be fighting to keep those changes. Everything from lower threshold, easier initiations, to flexibilities with take-home doses, but recognizing that in a lot of lower middle income settings, a person might not necessarily be able to afford to pay for the 7 days or the 28 days take-home dose. We need to be addressing the cost barriers as much as the drug policy barriers. We need flexibility for our pharmacists and flexibility in distribution. In our last webinar, we saw Morocco putting in place incredible new procedures to enable NGOs to distribute methadone to people who needed it outside city centres. I think going through this difficult period, there's no sector kind of better primed to respond and to innovate and to resist. You know, our core harm reduction principles of human dignity, of looking to the leadership from people with lived experience remains more relevant than it ever has been. And our interest in care for the whole person as opposed to one part of them is going to be relevant. But going forward, I think we all need to prepare ourselves, and this goes to what we were just talking about, for implementing harm reduction in even more resource constrained settings. We're talking about situations where people really have less than ever before all around the world, and particularly acutely in low income countries. So harm reduction has to mean shelter, it has to mean food, it has to mean mental health, it has to be more inclusive than ever before. And we need to fight for the funding for that, and we need to fight for the progressive policy changes that we've seen happen under COVID. We've never had a situation before where we see pragmatism rising above the controls of drug policy that have us so limited. So with that, thank you again to our fantastic panelists, Monica, Nicholas, Till, Maro, and Matt. Thank you to Ernst from MDM and Sam from MDM for all their work setting us up. And so final reminders, exciting news that Ernst is going to be setting up this mentorship program. Please reach out. Also, if you had a burning question, there's that COVID email address at the bottom of the web invite. Or if you have an experience you'd like to share with us in the next webinar series, the one after that, please write to that email address. We'd be really happy to hear from you. So thank you so much to everybody. See you again, I hope.